Comparing hepatitis A and E in children. Real hospital study results. Introduction. Hepatitis is an inflammation of the liver caused by viruses, toxins, or autoimmune reactions. Among the viral types, hepatitis A, HAV, and hepatitis E, HEV, are the most common in developing countries like Bangladesh. Both are transmitted through contaminated food and water and usually cause self-limiting infections. Hepatitis A is especially common in children and is caused by an RNA virus from the picornaviridae family. It typically spreads through poor hygiene and sanitation, with most Bangladeshi children exposed by the age of 6. While HAV infections are often mild in kids, adults can experience severe illness or liver failure. Hepatitis E, caused by the hepaviridae virus, spreads in similar ways but affects older individuals more severely, especially pregnant women, where mortality can reach up to 30%. Although HEV resembles HAV in symptoms, it tends to cause more cases of acute liver failure and sporadic hepatitis outbreaks in South Asia. Children with either HAV or HEV often show nonspecific symptoms like fever, nausea, abdominal pain, and jaundice. Overcrowding, poor sanitation, and unsafe water remain major risk factors in developing regions. Despite vaccines and preventive measures, millions of children are still affected every year. This study aims to compare the clinical features and outcomes of hepatitis A and E among children aged 1 to 15 years admitted to a tertiary care hospital, identifying key differences in presentation and prognosis. Rationale of the research. Hepatitis A and E virus infection is the most common cause of acute viral hepatitis in children in developing countries like Bangladesh. Though most of the cases improved spontaneously, but a few cases developed hepatic encephalopathy and acute liver failure, having high mortality rate. There is limited data about the clinical characteristics and outcome of acute HAV and HEV infection among children in our country. So, it is useful to detect any variability in presentation and outcome of AVH caused by HAV and HEV for proper management and disease control. Despite the availability of vaccines, prophylactic measures and improved sanitation, the rate of occurrence of acute viral hepatitis in children increasing day by day and still a major issue in developing countries. Early detection of acute viral hepatitis in children reduces the risk of acute liver failure and hepatic encephalopathy. So, this study will be helpful for proper management, reducing mortality rate and effective control of the disease. Research question. What are the clinical characteristics and outcome of acute viral hepatitis A and E in children aged 1 year to 15 years? Objective. General. To compare the clinical characteristics and outcome of the most common causes of acute viral hepatitis in children in Bangladesh. Specific. To see the rate of occurrence of hepatic encephalopathy and ALF among HAV and HEV. To identify the risk factors associated with hepatic encephalopathy and ALF. To see the rate of relapse and cholestasis associated with acute viral hepatitis caused by HAV and HEV. To see the duration of hospital stay to recover among HAV and HEV. Review of literature. Hepatitis A. Overview. Hepatitis A has been known since ancient times, with early descriptions by Hippocrates and ancient Chinese records. It became clearly recognized during world wars as battlefield jaundice. The hepatitis A virus, HAV, was identified by Feinstone et al. In the 1970s, and vaccines were introduced in 1991, leading to a sharp decline in infections in developed countries. HAV is a non-enveloped, positive-sense RNA virus of the picornaviridae family, hepatovirus genus. Humans and primates are its only natural hosts. 5 genotypes exist, but only I3 infect humans. HAV is highly resistant to acid, heat, and detergents, spreading mainly via the fecal-oral route through contaminated food or water. It remains endemic in low-income areas with poor sanitation and hygiene. Epidemiology. Globally, about 1.5 million HAV cases occur annually, causing around 7,000 deaths, WHO, 2016. In developed countries, infection rates have declined due to vaccination and sanitation improvements. However, outbreaks still occur via contaminated food and water. The disease is most common in children in Asia and Africa, where early life exposure leads to lifelong immunity. Pathophysiology. After ingestion, HAV reaches the liver via the bloodstream and replicates in hepatocytes. Liver damage results mainly from immune-mediated destruction rather than direct viral cytotoxicity. CD8 plus T cells and NK cells play major roles in clearing infection. Severe or fulminant cases may result from excessive immune responses or genetic variations, such as those in the TIM1 receptor. Clinical features. Most children are asymptomatic or develop mild disease, while adults often show more severe symptoms. The incubation period is 2 to 4 weeks. Typical symptoms include fever, nausea, vomiting, abdominal pain, dark urine, and jaundice. Extrahepatic manifestations, e.g., rash, arthritis, vasculitis, are rare. Laboratory findings. Aminotransferases, ALT, AST, rise above 1000 IU/L before bilirubin increases. ALT levels are usually higher than AST. Bilirubin levels peak within 2 weeks and then decline. Complications. Fulminant hepatitis, rare, less than 1%, prolonged cholestasis. Relapsing hepatitis, usually mild, autoimmune hepatitis, rare, treatment. No specific antiviral therapy exists. Management is mainly supportive, hydration, rest, and avoidance of hepatotoxic drugs. Vaccination remains the key preventive strategy. 2 types of vaccines are used globally: inactivated, US, Europe, and live attenuated, Asia. CDC recommends vaccination for children aged 12 to 23 months and high-risk groups such as travelers, MSM, and healthcare workers. Hepatitis E. Overview. Hepatitis E virus, HEV, is a major cause of acute viral hepatitis globally. First identified during unexplained outbreaks in India, 1950s to 1970s, HEV was visualized by Balayan et al. In 1983. It is a small, positive-sense RNA virus of the Hepaviridae family, with 8 known genotypes. Genotypes 1 and 2 infect humans via contaminated water, while genotypes 3 and 4 are zoonotic and spread through undercooked pork and wild meat. Epidemiology. HEV causes an estimated 20 million infections annually, with 3 million symptomatic cases and about 70,000 deaths, WHO, 2016. It is common in Asia, Africa, and Mexico, especially in areas lacking clean water. In high-income countries, sporadic cases are linked to animal transmission. HEV1 and HEV2 mainly affect young adults, 15 to 30 years, while HEV3 and HEV4 are more frequent in older or immunocompromised individuals. Pregnant women, particularly in the 3rd trimester, are at high risk of severe disease and mortality, 15 to 25%. Pathophysiology. HEV infects hepatocytes, triggering a strong immune response mediated by interferons and T cells. In immunocompetent hosts, this leads to viral clearance. However, in immunosuppressed individuals, infection may persist, leading to chronic hepatitis. HEV RNA has also been detected in the brain, kidney, and placenta, suggesting extrahepatic involvement. Clinical features. The incubation period is 3 to 8 weeks. Symptoms resemble other forms of viral hepatitis: fatigue, nausea, vomiting, fever, and jaundice. Most infections are self-limiting. However, 0.5 to 13% of cases progress to acute liver failure, particularly with HEV1. Extrahepatic manifestations. HEV can affect multiple systems: neurological, Guillain-Barré syndrome, encephalitis, Bell's palsy; renal, glomerulonephritis, cryoglobulinemia; cardiac, myocarditis; hematologic, aplastic anemia, thrombocytopenia; vascular, Henoch-Schönlein purpura. Laboratory findings. HEV RNA and antigens can be detected in serum and stool during early infection. Elevated ALT, AST levels, up to 10 times normal, are common. Diagnosis requires HEV PCR or detection of anti-HEV IgM, IgG antibodies. Treatment. Acute HEV usually resolves without treatment. Supportive therapy is sufficient in most cases. Chronic infections, particularly in immunosuppressed patients, may require ribavirin monotherapy for 3 months, achieving up to 78% viral clearance. Sofosbuvir has shown some experimental efficacy by blocking viral RNA polymerase. Prevention. Preventive measures include improved sanitation, clean water, and thorough cooking of meat. A recombinant HEV vaccine, HEV239, is approved in China but not yet globally available. Materials and methods. Study design. A prospective observational study. Study site. Conducted at the Department of Pediatrics, Shishu Hospital. Study period. From 1 year. Study population. Children aged 1 to 15 years admitted with clinical and laboratory evidence of acute viral hepatitis. Sample size. Based on the difference in acute liver failure rates between HAV, 22.9%, and HEV, 55.5%. Prashanth et al., 2018, calculated sample size equals 59.4 per group, right pointing arrow 65 patients per group. Total 130 participants. Sampling method, consecutive sampling of eligible patients. Inclusion criteria, children aged 1 to 15 years with newly diagnosed HIV or HEV infection. Exclusion criteria, hepatitis from non-hepatotropic viruses, e.g., torch, dengue, malaria, etc. Pre-existing liver disease, illness duration greater than 6 months. Refusal to consent, data collection procedure. Ethical approval was obtained from the ERC. After informed consent, clinical history, presenting symptoms, hygiene and food history, and examination findings were recorded. Blood samples were tested for anti-HIV IgM, anti-HEV IgM, ELISA, and other labs, SGPT, bilirubin, PT, INR. Patients were monitored daily for signs of hepatic encephalopathy and acute liver failure, ALF, and followed until discharge. Stage 3 encephalopathy cases were referred to PICU and followed by phone. Data processing and analysis. Data were entered and analyzed using SPSS version 25. Chi-square test for categorical variables. Students' t-test for continuous variables. P less than 0.05 considered significant. Odds ratio, OR, and 95% C calculated for associations. Ethical considerations. Informed written consent was obtained from guardians. Participants could withdraw at any time without affecting their treatment. Confidentiality was strictly maintained. Ethical approval was granted by the hospital's ethics committee. Results. This prospective observational study compared the clinical characteristics and outcomes of hepatitis A virus, HIV, and hepatitis E virus, HEV, infections among 130 pediatric patients admitted to a tertiary care hospital. Distribution of hepatitis types. As shown in Table 1, hepatitis A was the predominant infection, accounting for 95.4% of cases, while hepatitis E represented only 4.6%. This indicates that hepatitis A remains the more common cause of acute viral hepatitis among children in this population. Demographic characteristics. Table 2, the majority of HIV-infected children, 79%, were older than 5 years, whereas all HEV cases occurred in children above this age group. Although the age difference was not statistically significant, it suggests HEV affects relatively older children. The male-to-female ratio was comparable across both groups. Urban residence was significantly more common among HIV cases, 83.1%, compared to HEV, 50%, P equals 0.041, indicating higher HIV incidence in urban areas. Socioeconomic status showed a significant association, P equals 0.006, with most HEV cases clustered in the lower middle income group, 10,000–20,000 Bangladeshi takas. No significant association was observed with parental education, sanitation, safe water, or hygiene practices, though HIV subjects generally had better sanitation and access to safe water. History of jaundice. Table 3, previous and family histories of jaundice were not significantly associated with either type of hepatitis. This suggests that recurrence or familial clustering of jaundice was uncommon among the study subjects. Clinical features. Table 4, most clinical features were similar between HIV and HEV infections, including fever, jaundice, anorexia, nausea, vomiting, diarrhea, and abdominal pain. However, constipation, P equals 0.001, and hematemesis, P equals 0.002, were significantly more frequent in HEV patients, implying more severe gastrointestinal involvement. Neurological symptoms such as seizures or unconsciousness were rare in both groups. Presenting complaints. Table 5, both groups showed similar physical findings such as fever, jaundice, hepatomegaly, and anemia, with no statistically significant differences except for pruritus. P equals 0.016, which was more common in HEV patients, 33.3% versus 6.5% in HIV. This could reflect mild cholestatic manifestations in HEV infection. Biochemical parameters. Table 6, biochemical findings were largely comparable between groups. Although most differences were statistically non-significant, decreased hemoglobin levels were more frequent in HEV patients, 83.3% versus 19.4% in HIV. P equals 0.001, indicating a tendency toward anemia in HEV infection. Liver enzymes, SGPT, coagulation parameters, PT, INR, ESR, and bilirubin levels did not differ significantly, suggesting comparable hepatic injury patterns in both infections. Outcome. Table 7, clinical outcomes were favorable in both groups. Recovery rates were high, 95.2% in HAV and 100% in HEV cases, with no reported deaths. Complications such as hepatic encephalopathy and acute liver failure occurred only among HAV patients, 0.8% and 4.0%, respectively, but these differences were not statistically significant. The results suggest that both HAV and HEV generally follow a self-limiting course in children, with low complication rates. Duration of hospital stay. Table 8. Most patients had a hospital stay of 5 days or less, 65.3% for HAV and 83.3% for HEV. The mean duration of stay was slightly longer for HAV, 5.16 plus or minus 2.09 days, compared to HEV, 4.83 plus or minus 3.60 days, but this difference was not statistically significant. P equals 0.363. Thus, hospitalization duration was comparable across both infections. Overall interpretation. In summary, hepatitis A was the predominant type of pediatric viral hepatitis observed. While clinical manifestations and biochemical profiles were largely similar between HAV and HEV, the latter showed higher rates of constipation, hematemesis, pruritus, and anemia. Urban residence and socioeconomic status were significantly associated with disease distribution. Both infections generally had favorable outcomes, short hospital stays, and no mortality, underscoring the self-limiting nature of these viral hepatitis in children under proper supportive management. Discussion. Acute viral hepatitis is an inflammation of the liver caused by hepatotropic and non-hepatotropic viruses, with hepatitis A, HAV, and hepatitis E, HEV, being the most common fecal oral transmitted types in developing countries. This study compared the clinical characteristics and outcomes of HAV and HEV infections in children aged 1 to 15 years. In this study, HAV infection, 95.4%, was far more prevalent than HEV, 4.6%, consistent with findings from Das et al., 2021, and Behera and Patnaik, 2016, who also reported HAV as the leading cause of pediatric hepatitis. Despite improved hygiene and HAV vaccination in some regions, HAV remains common in countries without routine immunization, Yan et al., 2019. Most patients were older than 5 years, with all HEV cases occurring in this group, similar to findings by Behera et al., 2016, and Mahmoud et al., 2017. This pattern may reflect greater exposure to contaminated food and water among older children. Males were slightly more affected, aligning with studies by Yusuf et al., 2020, and Rana and Lone, 2021, possibly due to behavioral and environmental exposure differences. Fever and jaundice were the most frequent presenting complaints, consistent with Das et al., 2021, and Semwell et al., 2019. Clinical comparison showed similar symptoms between HAV and HEV, though pruritus was significantly higher in HEV cases. P equals 0.016, supporting findings by Gurish et al., 2018. Hematological and biochemical findings were comparable across groups. Anemia was more frequent in HEV-infected children, 83.3%, than in HAV, 73.5%, though not statistically significant. Liver enzyme elevations, SGPT, SGOT, and bilirubin increases were common in both groups, confirming similar hepatic involvement as reported by Das et al., 2021, and Gampa et al., 2022. Outcomes were favorable in both infections. Recovery occurred in 95.2% of HAV and 100% of HEV cases, with no mortality and only one case of hepatic encephalopathy in HAV. These results align with earlier reports highlighting the self-limiting nature of HAV and HEV in children when properly managed. Rashid et al., 2022. In summary, hepatitis A remains the predominant cause of acute viral hepatitis in Bangladeshi children, while HEV cases are less frequent but may show slightly more severe gastrointestinal and hematologic manifestations. Both infections generally have excellent prognoses under supportive care. Conclusion. This study shows there is no significant difference in hepatitis A and hepatitis E. Both cause same symptoms with similar examination findings and biochemical profile. Vaccination against hepatitis A should be part of routine immunization program. Health education should be provided to the general public regarding preventive measures, including the use of safe drinking water, proper hand hygiene, proper waste disposal, and the use of sanitary latrines. Awareness of the clinical symptoms of acute viral hepatitis is also important for the early identification and seeking of medical attention so as to prevent morbidity and mortality related to the disease. Limitation. The limitations of the present study include that it was a hospital-based study, which may not be representative of the community. Furthermore, it was a single institution research and further studies would be needed to test whether the same findings are applicable in other areas too. Recommendation. Support a good relation among pediatric specialists. Advance investigations to exclude organic causes of acute viral hepatitis. Making a vaccination for children. Strict follow-up for acute viral hepatitis patient to assess further chronic morbidity.